Because those cranial bones and vertebrae are not ossified, baby brains and spinal cords are at higher risk of injury from trauma. Myelination is incomplete at birth. Ever notice how when you stick a baby or give them a shot, they don't immediately cry? That's because they don't have full myelination of their nerves. Myelination accounts for the development of gross motor skills like walking, jumping, climbing stairs, and for improving the speed of neurotransmission. The loose ligaments allow more movement, but it also comes at the price of increased risk of injury. The brain is well protected, but still vulnerable to pressure that may accumulate within the cranium. And this is just a good graphic because it shows the meningeal layers. So why do we care about the altered states of consciousness? Why do we even bother noting this? Because a change in the level of consciousness is the earliest indicator of improvement or deterioration in neurological status. That's why we care. So full conscious means that they are awake and alert and oriented times 3. Confusion would be they have impaired decision making. Disorientation means they have disorientation to person, place, or time, or a decreased LOC. Lethargy means limited spontaneous movement, sluggish speech, that they're drowsy, they fall asleep quickly. Obtunded means that they arouse with stimulation. Stupor means that they are in deep sleep or unresponsive state, or they have a very slow response to vigorous and repeated stimulation. They may moan to stimuli. Comatose means that they are unconscious, even with painful stimuli, no verbal or motor response or postures with noxious stimuli. And PVS, or persistent vegetative state, that means that there is permanent loss of function of the cerebral cortex, retaining reflexive responses only. So the causes of altered LOC, they're listed for you on your slide. And then the big question is, why do these things alter the LOC? And the reason is because they can all cause increased ICP, and with increased ICP, you also get decreased cerebral perfusion pressure, decreased CPP, so you get a reduction in the arterial blood flow to the brain. So, things that cause changes in LOC generally are the result of things that cause increased ICP, which results in decreased cerebral brain perfusion. That's why we care. It's a big deal. So say that you were in clinical and your clinical orders were to go and conduct a pediatric neuroassessment. What in the world would you do? Besides look at your instructor or look at your classmates and go, it's one of those sketchy things that's kind of hard. You want to assess the level of consciousness. Ask, is the child difficult to awaken? Is the child irritable or difficult to calm and console? Is the child oriented? Can they state their name? How is the child's concentration? Are they sitting in their bed, staring intently at the TV, concentrating playing the Wii or Mario Kart? Or are they concentrating reading a book or concentrating just watching TV? You want to check the Glasgow Coma scale. The Glasgow Coma scale quantifies the level of consciousness. There is PEDS criteria for pre-verbal children as well, just FYI. And the Glasgow Coma scale is good because it allows for comparison and the tracking of the LOC. Vitals. You want to assess, does the child have a fever or hypothermia? Because that can be a sign of sickness or ingestion of something. Skin, look for lacerations, bruising, needle marks, petechiae, bites, ticks. Sometimes there may be evidence of toxic substances on hands, mouth, and clothing of children. Assess the pupil size and the reactivity. If they're able, assess the child's movement and their gait. Are the movements spontaneous and are they purposeful or non-purposeful? Posturing, we'll talk more about this on the next slide. Reflexes, the corneal reflex. Most of the time nurses are not going to check this. Physicians are usually the one that check that. But nurses can check the pupillary reflex, muscle stretch, superficial, plantar reflexes. Those will all be absent in a deep coma. Absence of reflexes and presence of a tonic neck are associated with severe brain damage. I'll say that again. Absence of reflexes and presence of a tonic neck are associated with severe brain damage. And we'll look at posturing on the next slide. This is a power-packed slide. First, I want you to look at that table that I put on there. It's signs of increased ICP. So I want you to look at the early signs and then look at the ones that are specific for the infant. Irritability, bulging fontanelle, wide sutures, dilated scalp veins, high-pitched cat-like cry. Oh, these are important things to know. And then late signs, you guys should also know about Cushing's triad, and you can read about that on your slide. The top picture shows the boy flexing, or that's the flexing or the decorticate, and it is associated with lesions above the brainstem in the corticospinal tracts. Extensor or decerebrate is associated with lesions of the brainstem. That's the bottom picture. In both of these, the child is rigid, either with rigid flexion or with rigid extension. So what you do is apply a noxious stimuli to the child and then see what they do. See if they do the decorticate or the decerebrate posturing. And that kind of gives you a clue about where the injury is. Diagnostic tests and procedures, lab tests. Why do we care about lab tests? Because if our electrolytes are out of whack, it can cause behavioral changes, right? We're going to do an EEG because we want to check brain function and activity. We're going to do an LP. LPs should always be postponed for any signs of increased ICP. Increased ICP places a child at risk of brain herniation. That's why. And then they can do other imaging. There's a whole table in your book you can read over. Nursing care for the unconscious child. This is a child who comes into the ER, child that you happen upon when you're out bike riding in your neighborhood. Hopefully you won't ever find that. Again, just to beat a dead horse again and again and again, emergency management is always airway, breathing, circulation. You have to stabilize the spine, treat shock, and reduce ICP. Delayed treatment means increased damage. Again, your assessment includes all these things listed. Manage and treat pain. Managing pain requires astute nursing observations. Treatment with opioids is somewhat controversial. Fentanyl plus midazolam or Versed plus vercuronium as a paralytic. Acetaminophen and codeine can be used. You need to make sure that the child is having adequate dosage and regular administration. You want to make sure the child is comfortable. And then other things we can do to decrease ICP, keep the child in a quiet, dimly lit room. Make sure parents aren't fighting and stuff outside the hospital room if you have to. You can read about the different types of ICP monitors on page 1425 to 1426 in your textbook. In caring for a child with increased ICP, it's important to avoid activities that will increase ICP. Things like suctioning and percussion, like from CPT, are generally poorly tolerated and usually contraindicated unless there are respiratory problems that must be addressed. Instead of percussing, they can do vibrating CPT, and that works much better for both problems, the secretions and the ICP. If you must suction, pre-oxygenate with 100% O2 and suction only as required. More nursing interventions for nutrition and hydration. Initially, the child will be on IV parenteral nutrition. TPN and lipids is what you're looking at. You want to avoid overhydration. Later, as the child starts to recover They may switch them over to gastric feedings via a NG or a G tube. Obviously, continued and close monitoring for aspiration would be important if you're going to do any type of tube feeding. Monitor for SIADH and diabetes insipidus. That may accompany central nervous system diseases. Altered pituitary secretion may result from hypothalamic dysfunction. SIADH results from head injury, meningitis, encephalitis, brain abscess, brain tumor, subarachnoid hemorrhage. Scant urine is excreted. Labs are going to reflect hyponatremia and hypoosmolality and overhydration. So what do? You're going to restrict fluids until fluid levels come back down to normal. In contrast, diabetes insipidus can occur after intracranial trauma. In diabetes insipidus, there's so much urine that dehydration is the concern. Labs are going to show hypernatremia, hyperosmolality. Vasopressin may be given to slow down the urine output. Medications, antibiotics for infectious processes, corticosteroids for inflammation and edema. The child may also need to be on sedatives or anti-epileptics, sedation or amnesia, anti-anxiety medicines, barbiturates, somewhat controversial, and paralytic agents. Thermoregulation, hyperthermia often accompanies cerebral dysfunction, so you treat the fever to reduce the metabolic demands on the body. Did you guys realize that? Oftentimes when kids have cerebral dysfunction, they will run a fever. So it is important to treat them, to treat the fever, so you can reduce the metabolic demands. External cooling is usually needed as Tylenol and Motrin generally won't work in the cases of brain injury. I'm going to say that again because I can guarantee you I'm going to test you on that. Tylenol and Motrin generally will not work to bring down a fever in cases of brain injury. In addition, if you are concerned about somebody's fever, what is the fastest way to bring a fever down? If you take a PO med in a child, or even if you give, you can give, like IV Tylenol or IV Motrin or whatever, you don't really do that. But if you give something PO, you're looking at 30 minutes onset. But if you do external cooling, you can begin to bring that fever down immediately. So again, I'm going to say it again because it's really important. External cooling generally is much more efficient than Tylenol and Motrin because they do not work to bring down fever in the cases of brain injury. All right, I'll get off my high horse now. Elimination. As a nurse, you're going to end up putting in a catheter and you're going to give suppositories as needed to prevent fecal impaction. Hygiene, it's very important. Make sure you brush these kids' teeth twice a day. That's just gross. You all know how disgusting it is when you go 12 hours without brushing your teeth. These kids go days and days, so make sure you brush their teeth. You can put chapstick on if they need it. Watch the eyes and make sure that they are not getting too dry. And then for positioning and exercise, keep the head of the bed elevated 30 degrees unless you have an order to do something different. The child can be placed side-lying or semi-prone to prevent aspiration of secretions. You do what you can to maintain normal body position. More interventions. Stimulation. You want the parents to hold the child's hand, if possible. Have them talk to the child. When the child starts regaining consciousness, they may appear upset, they may be withdrawn. They will usually answer basic questions, but they may not wake up to their normal personality. If they get it back, it will be later when they are not in the ICU. Family support, it's the same emotions we've already talked about. Guilt, fear, helplessness. Maybe these parents need to grieve at the loss for the child they knew and for the child that they have now, if there is permanent brain damage and injury.